Check 1, 2.
Dia obagi
Thank you, Kapila. On behalf of the College of Ophthalmologists of Sri Lanka, I warmly welcome all of you for this hybrid clinical meeting, an overview of common ocular disorders organized by our college. It is a privilege to conduct this clinical meeting for members of the oldest national organization of general practitioners in the world, the Independent Medical Practitioners Association of Sri Lanka, which was established as far back as 1929. The then Ophthalmological Society of Ceylon, founded in 1957, which later became the College of Ophthalmologists of Sri Lanka in 1991, is the second oldest specialist association in the country. Hence, I believe today is a special and a memorable day where two most oldest medical organizations of Sri Lanka have met to share knowledge and experience for the betterment of the practice of medicine. At the outset, I would like to thank Dr. Ananda Pereira, the current president of the IMPA, for supporting us to organize this event. The five speakers who are here today are senior and eminent ophthalmologists in the country who have come forward to enlighten you on the common causes of preventable blindness, not only in Sri Lanka, but all over the world. Indeed, I'm very grateful to all of them for being here today to share their knowledge and expertise with you. The main aim of our college is to combat these causes of preventable blindness in the country by not only enhancing the aspect of curative care, but also working hard to upgrade the aspect of preventive care. Thus, we are involved in organizing and conducting regular awareness and education programs for general practitioners, for medical officers, public health inspectors, public health midwives, and all others in preventive care. I would like to take this opportunity to thank Elegant Eye Care of Sri Lanka for sponsoring this program. I sincerely hope that this clinical meeting would be beneficial to all the members who are here today who are participating in this clinical meeting. Thank you. Now I would like to invite Dr. Ananda Pereira to address the gathering.
Thank you, Madam. Good evening, distinguished keynote speakers, Madam President of the College of Ophthalmologists of Sri Lanka, and the EXCO members of both the College of Ophthalmologists and the IMPA, and distinguished invitees, guests, and virtual attendees. Let me first welcome all of you again to this unique event. The theme for today's CPD activity being the common ocular disorders in primary care. The concept of primary care ophthalmology, of course, had been there for the last 10 to 15 years. The Royal College of Ophthalmologists also endorsed the concept and they actually support it. This particular event seems to suggest the agreement of our Sri Lankan ophthalmologists also with this concept. In view of the competing interest of many other professionals as far as the primary care ophthalmology is concerned, I think we as primary care physicians should embrace this support given by the College of Ophthalmologists currently. A panel of best of the breed Sri Lankan ophthalmologists are really waiting to update you on this theme. And please make maximum use of this rare opportunity to serve your patients with eye problems who are spreading across the length and breadth of Sri Lanka. Thank you.
To deliver the first lecture, I would like to invite Dr. Sali Patirana, consultant ophthalmologist and vitreoretinal surgeon of Golden Key Eye and ENT Hospital and City Central Hospital of Colombo. He is one of the pioneers in advanced vitreoretinal surgery and phacoemulsification surgery, which is sutureless cataract surgery. He has trained the younger generation for cataract surgery and is a past president of the College of Ophthalmologists of Sri Lanka and a past president of the Association of Vitreoretinal Specialists of Sri Lanka. Over to you, sir.
press this one. To go down. It will maximize. Make a increment. Okay. Good evening, and thank you for inviting me to deliver this lecture on cataract and cataract surgery, one of the very common topics today, and one of the commonest diseases affected one of the commonest eye diseases that we are all involved with. I will just start with some pictures of cataract. Right? Now, we all know where the lens is in the eye, inside the eye, so I have not put a diagram on that, but these are the pictures to show you some opacities in the eye, lens of the eye. So the first picture, if you look at the first one, so the pictures haven't come. By definition, the cataract is any opacity in the crystalline lens. The pictures make I know. Na?
It will take some time, sir, because the zoom is coming. It's going through zoom.
So I have to wait?
Yes.
Okay. So while I'm waiting, I just explain what a cataract is. A cataract, as you all know, there is a lens inside the eye, a human lens, which is transparent. And it's a living lens. All the biochemical reactions are going inside the eye, the ATP production and the energy production. It's a living eye, not living lens, not like a artificial lens. So with time, all these chemical reactions will take, some changes will take place. And the lens is actually made out of protein. So the proteins will change, and with the change, the transparency will reduce, and finally the opacities will come. All right, okay, that's it. Now, if you look at the first picture, I'm sure that is clear. There's very slight stromal opacity in the, can you switch off this light? Knock off this light will be better. Okay. Look at the first picture, you can see very slight opacity in the lens, and there's a stromal opacity. Pictures on it. My pictures to go on a method. Okay. Can you change current? Okay. Now, this is a very slight opacity in the lens. That's the start of the cataract. And then finally, you can see somewhat a bigger opacity and then slightly bigger one. And then finally, half of the lens is opacified here. And then this is another type of cataract where the center is clear, but the periphery is changing and the opacification is coming. So Now, finally, if you, those are of course against the red reflex, these pictures are taken with the slit lamp. But if you look at the last one, you can see this white lens, which is a somewhat of a moderate cataract. Say, with time it becomes worse, and sometimes you get a nuclear cataract. These are not changing fast, right? Change. You can do that.
It takes some time, sir. And you can.
We continue in that.
That's fine.
Yes, right. Now, if you look at this lens, there's a central opacification. It's a sort of a nuclear cataract. The center of the lens is opacified, and this type of patients, usually their vision is fairly good, especially near vision is good. But first, what happens is their distance gets blurred, but gradually the near gets worse. But these people, now sometimes when you say that you have a cataract, they deny. They say, no, I can see very well because their near vision is good. But I will show you the next slide, but some different type of cataract. Now, this is a posterior capsule opacity. It's coming up slowly. You can see it's getting worse. And there's a huge patch here. Now, this type of patients will have more disturbance than a nuclear cataract. Because these people, when the light hits the eye, the pupil constricts. And the moment the pupil constricts, their vision becomes less. So they will find it very difficult to drive and very difficult to drive in the sunlight and especially in the night. And of course, even reading will be very difficult. These people will be affected more than any of those other type of cataracts. These are posterior subcapsular cataract. And they will find the vision is very much better inside the house in a dim vision. So if a patient comes and tells you that in the bright light I can't see, that means they have a posterior subcapsular cataract. Now, finally, if you allow that cataract to grow, it will come to this stage. That's a very mature cataract. The vision will be very poor, and most probably it's hand movements. They won't be able to see other than light after some time. So they will need surgery immediately. Otherwise, their vision will be really down. But there are people who have one eye like this, the other eye fairly okay, and they come at this stage because they don't realize that one eye is really bad. So when they come, one eye will be like this. Now going back to, so we'll see what are the causes of cataract. Now mostly, the most common thing is age. So the cataract will be formed, anybody who is about 60, so that's the age-related cataract. But the cataract can form even better below 60, any age. Nowadays, there are patients who are coming even 40s, 30s. Mainly due to, if a younger person has cataract, you have to think about a secondary cause, something like diabetes. So diabetes, if the patient is diabetic, they can get early cataracts. And then any metabolic disorder, or they are taking any steroids. Steroids. The other causes are like toxic substances, any injury to the eye, any surgery, ocular surgery can cause a cataract. Of course, there are congenital type of cataracts, where some families, they have autosomal dominant type of cataracts, so they are born with cataracts. And on top of that, there can be intrauterine problems like rubella virus, or else any other viral diseases. Some of the viral diseases can cause intrauterine cataracts. Then any trauma, at least slightest trauma to the eye can cause a cataract, like a surgical trauma as well as any outside trauma. Anything hitting on the eye, you might find a little later the patient developing a cataract. So what are the symptoms? Symptoms, usually they get cloudy vision, the blurring of vision. If they have posterior subcapsular cataract, they will find it very difficult with the light, but generally their vision will be blurred. They might find increased difficulty in the night and dim light. And sometimes they might see halos, very rare, but some people might complain of halos because the light going through the opacified eye can change into different colors. So another thing is if they need to change glasses very frequently, probably maybe the cataract is growing. And sometimes they may be having a color vision problems. And a single eye double vision also may be a reason that they have a cataract. Because usually you get a double vision with paralysis of one of the muscles in the eye. That's usually they see double with both eyes together. But if you cover one eye, the diplopia disappears if it's a muscle palsy. But if the patient comes with double vision after covering one eye, that means it may be the cataract which is causing that double vision. But that double vision is not the same as that paralytic double vision. It will be something like a ghost image. The image plus another image on the side due to cataract. Then those days, what happened was these intraocular lenses were not available. So the general practitioners were asked to wait as long as the patient can see with their own lenses. So they watch till the late stages as long as the patient can see. Nowadays it's different because we can replace the lens with the intraocular lens. General practitioners can refer the patient much earlier than those days. If the patient says that his vision is disturbed and his normal day-to-day life is disturbed with the vision, and that's the time to refer them for cataract surgery. And the other thing is that today the patient's life expectancy is so long, they live longer, and on top of that, they watch television, they detect their vision is blurred much earlier than many years ago. So older generation, they are the ones who are watching television more, the retired crowd. So they will realize that the vision is blurred, not like those days. So they will come to the general practitioner. So I will tell you how to detect a cataract later. So referring early is the usual practice today because we can replace the lens. Anybody who has a blurred vision with cataract. So anyway, the crystalline lens, which is a transparent lens we have in our eye, will start changing with time. Especially at the age of 40, it changes and we get a condition called presbyopia. That's the start of the change. And after that, it will start changing. So at the age of 60, your accommodation is mostly completely lost. And then the cataract might start. Some people now who has lost their near vision might find it easy to read when they develop a cataract. So if somebody comes and tells you that all this time I couldn't read, now my vision is getting better and I can read, that means they are developing a cataract, most probably at the age of 60, if they say so. They call it like my grandmother getting second vision, because the grandmother who couldn't see all this time suddenly she'll start finding that she might find that she can read now without glasses. So that means she's developing a cataract. The near vision getting better at the age of 60, between 60, 70, that time. You have to suspect a cataract if they say suddenly I can see near, but the distance is getting blurred. So if a patient comes with cataract or the complaining about blurred vision, about 60, and it's you have to remember that's a gradual change. If a patient comes and says suddenly my vision is getting deteriorated, that can't be a cataract. So a patient will realize that it's gradually changing. So gradual change of vision, that's number one. And then you check the visual acuity. You might find that it can't, if the cataract is not dense, the vision is generally about 618, 612, 636, that level. Most probably there will be a pinhole improvement. I hope that you all know what's a pinhole test. You look through a pinhole and look at the visual chart, and the vision improves. That means it mostly probably a cataract. If they have a macular problem, basically retinal problem, that pinhole vision won't improve. So if the pinhole vision is improved, that means most probably it's a cataract. As a GP, you can detect that by checking the visual acuity and then doing the pinhole test. If the pinhole test doesn't improve vision at all, that means it's more than a cataract, most probably. It can be a macular problem or retinal problem. You have to refer the patient to an ophthalmologist. Then, of course, you can, if you can, the next thing is to correct the vision with spectacles. If you can go get the best vision with the spectacles, and if the patient is ready to wear spectacles, we can postpone the cataract surgery. Then the slit lamp examination, we will check the cornea, entry chamber, iris, then dilated eye, and then we look at the lens to see whether there are any opacities, and then the vitreous, and then we look at the retina to see whether there are any retinal problems. Then these are the type of tests we do if a patient comes with suspected cataract. And of course, if, as I told you, that there's a mature cataract, which we can't see the retina, we usually do ultrasonography and ultrasound examination to see whether the retina is attached. But if there are macular problems and all, sometimes it's not that easy to detect if there's a mature cataract. But of course, if there's some sort of transparency in the lens, we can do OCT test to see whether there are any macular problems before cataract surgery. Now, when to do the cataract? I was just telling you some of the points earlier. The main thing is, it depends on the patient's age, occupation, and type of lifestyle. So if a person who is retired, maybe 80s, waiting at home, only watching TV, that person may not need so much accurate vision. Whereas another person who is 50 to 60, working, driving, doing all the work, then of course that person might need cataract surgery earlier than another person who is so much inactive and waiting at home. So it depends on the job and type of lifestyle. But of course today, even at 70, 60, they are watching TV, and they might demand that they want better vision, not like those days. So all this depends on the type of work, age, and all that. Of course, one thing I have to remember is we don't have to do the cataract immediately. If they're happy, they can see with the specs, we can postpone. And postponing the cataract won't make a difference of outcome after surgery. So whether we do it at 65, so your patient is happy, the patients sometimes ask you, when I tell them that you have a cataract, you might need surgery to improve vision, they ask, if I postpone this by 6 months or 1 year, will it affect my vision? That is, if you do this after 1 year, is outcome going to be worse? No. Whether we do it today or after 1 year, as long as the retina is normal and the macula is normal, outcome is going to be the same. It doesn't matter postponing. The cataract won't affect the retina or the other segment of the eye to make the vision worse. So postponing is not going to make the vision worse after surgery. So if you are going to postpone the surgery, so periodic follow-up is necessary to see how the cataract is growing and how the patient is faring. Then we have to discuss with the patient with various types of lenses available. You know, there are different prices for the lenses depending on the quality, depending on the manufacturer. So there are various types of lenses called multifocal lenses, toric lenses. I'm not going to go into detail, but we have to discuss with the patient. If you are going to put a monofocal lens, then what's the difference with the multifocal lens? The multifocal lenses are more expensive. Multifocal means they give you distance vision, intermediate vision, and near vision. Now today there's a new lens which has come out called Panoptics, which I used. Extremely good because patient has very good vision with the distance, intermediate, and near without spectacles. But that particular lens is very expensive. Average person can't afford it because the lens is about 150 to 160,000, whereas the normal average lens is about 17,000. So you have to discuss with the patient. And then on top of that, multifocal lenses have their own problems because they have this glare with the lights and halos, different problems. And then you can't guarantee 100% near vision and distance vision. You have to tell the patient it's about 98%. But maybe even after this expensive lens, you may have to wear spectacles for reading sometimes. So you have to discuss with the patient very well if you are going to use a multifocal lens. Because the moment they spend 150,000, their expectations are very high. They will think that they'll be able to see everything. And if they say halos, glare, they are going to come and complain and you will be terrible problems. So far, panoptic lens, I didn't have any problem. Most of the patients are happy, but only problem is some patients still complain of glare and halos, but I don't think it's as much as bad as the earlier multifocal lenses. This is the latest one, but very expensive. Then the toric lenses are to correct patients who are having astigmatism. Now, people who have astigmatism have to wear specs, but we can correct the astigmatism part also with these toric lenses. Toric lens is not as expensive as the multifocal lens. It's around maybe 55, 60,000 rupees. People who can afford and who have astigmatism can go for it because then they don't need to wear spectacles. But of course, there's another method of correcting distance and near by using these monofocal lenses. We do monofocal correction. That is, we do one eye completely for distance and the one eye for somewhat reading. And most of the patients are happy actually with that method, where one eye focusing for distance and one eye intermediate and near, both eyes together, they can see near and distance both. And lots of people managing very well, which I have done that. So talking about the premium IOLs are the ones I'm talking about, all these multifocal lenses and toric lenses. Then I'm going to show you a small video. This animation, just for you to watch. How it is done, but today, putting drops onto the eye, we anesthetize the eye. Okay, now that's in animation, but I will show you a real world situation where I was doing a cataract and I have recorded the procedure. So this is how we do it in the real world. Same thing, the incision, 2.2 millimeter incision, very small incision, whereas those days it was 6 millimeter incision long ago, but today it's 2.2 millimeter incision. We don't take the lens out. Those days they used to take the lens out. Now we don't take the lens out. Instead we emulsify the lens using phacoemulsification. Okay. Then there's a viscoelastic injected into the antechamber to keep the space and to prevent damage to the cornea. That's a special substance called viscoelastic. And there will be two side incisions to enter, and then we use a bent needle or capsulexis forceps to make a curvilinear incision on the lens. There can't be any jagged edges to prevent it tearing. So it should be a very regular curvilinear cut, just like that. And then there will be a certain amount of hydrodissection done. And this is the phacoemulsification, where we are using the probe with ultrasound energy to break the lens into small pieces and take it out. This is a fairly hard cataract. You can see it's a bit of a hard, dark yellow color. And we break it into pieces like this, one by one, slowly. And then each piece is taken out using the ultrasound energy and suction. You can see how one by one is coming out, leaving the capsule intact. We are taking the stroma and the nucleus out, and the capsule is intact now. Again, we use irrigation aspiration probes to take the stroma, whatever the left out lens matter, separately. This is how it is done, bimanually. Change hands to take the other side out. Finally, it will be like this, clear capsule left. Now the vitreous is separated with that capsule. So you have to be very, very careful not to rupture the capsule during this procedure. Then we implant the lens, a folded lens, inject it into the entry chamber, and it starts spreading out inside the capsular bag. So this is how we complete the procedure. So that is how the phacoemulsification and intraocular implant of the eye lens done. So this is another one which is a very mature cataract, a different method. I'll quickly show it. That's a bit of a different tricky situation where the capsule is very thin and it can go out of the space if you are not very careful. So it's very, very carefully you have to do the capsulexis here in a condition like this. It's a very mature cataract. Again, still the same thing. Break the nucleus into small pieces. And finish the removal of the lens matter, and the nucleus is done using the phaco power, the ultrasonic power. Similar thing, again implant the lens, but it's a much more difficult situation, difficult condition than a normal the cataract. So the patient should come a bit earlier than this condition. Otherwise, the surgeon will face bigger problems than a normal cataract. So you have to explain to the patient the procedure and the complications and type of problems he can face before surgery. And then you have to tell the patient that might have to wear specs for reading. And some people patient may have unrealistic expectations. So you have to be careful by explaining them the whole procedure before surgery. In fact, some patients who come like that with that white cataract can't see anything. But you might find after about 1 month later, they come and, complain so many other things, irritation. Now, recently I did a cataract like that. A man came after going to Ayurvedic treatment for some year or something, completely blind. Couldn't see anything, only light. I did the cataract. I thought he'd be very surprised to see so much. Following day, he could see everything. But 5 days later, he came and told me, I can see a small dark spot moving around here, and he was complaining. The man who couldn't see at all. So that's how our patients' expectations today, because they have unrealistic expectations beyond what we can deliver today in the 21st century. So especially when they come to the scientific side of medicine, not to the other side. So post-operative care, generally their vision will be restored even the following day if you do a very clean cataract surgery. Of course, they will have some sort of irritation, sort of, moving like feeling. So the first thing they will tell is that, I feel like something is moving, irritation and tearing and all that. So that we use medicines. We usually use steroids to prevent the inflammation. And then, of course, NSAIDs to prevent the inflammation and the macular edema. And then antibiotics to prevent infection. So these are the 3 drugs usually we use after surgery. So whenever they complain, I say, okay, use the drops, then you'll be fine, and they usually go. The first day, usually we check them and listen to their problems, their complaints, and then we advise them how to use the drops. In the case of severe redness or pain or something, how to report back, because the infection is the worst situation where we can get after surgery, called endophthalmitis. So we have to warn the patient that after surgery, after 1 or 2 days, if they feel that the unusual pain, unusual redness, unusual tearing, if the vision is blurred, immediately come back and report back to the surgeon. So then usually after 3 to 4 weeks later, we see the patients again, if there are no problems before that, and then only we do the refraction and correct their vision with spectacles. Of course, they will come even after 10 years. I have patients whom I have operated maybe about 20 years ago, suddenly come to you saying, Dantika kaduine and all, right? So that's how they are. 20 years later, they expect that the vision has to be the same. Nothing can change. They'll come and say, look here, now my vision has deteriorated slightly. That's why I came. Of course, I think it's reasonable because, they want the vision. You have to bear with them and explain to them and say something and, give some drops. Okay, they'll be happy. Complications. Of course, complications are rare today with all this advanced technology and good surgeons, and the surgeons are very well trained today to do phacoemulsification. So complication rates are very much less than the time we started phacoemulsification, very much less. So very rare to get wound leaks today, not like the days we use suturing. And then somewhat, the bad cataracts like that, if you use phaco power a lot, ultrasound power a lot, they can have some sort of a corneal edema. Usually they disappear within a week or 2. You have to reassure the patient and say, very rarely you can have cataract, small fragments getting isolated and couldn't remove and go under the iris and getting, standard there. They might get inflammation. So some patients, we might have to remove this type of fragments, but they also usually get absorbed. Rarely we have to go in and remove. Then, of course, inflammation. Time to time, they can get inflammation and come back. Then you have to use steroids. And then some, of course, complicated cataract surgery where we have rupture of a capsule or something. Then, of course, we will have more problems. Like vitreous coming out, vitreous getting attached to the wound, so much of pain, inflammation. Of course, that has to be managed separately if you had a bad complication during surgery. Then the endophthalmitis, I told you, infection is the worst thing which can happen, to be careful. And it depends on the type of place you do, the sterilization technology, the surgeon's surgery technology, surgeon's experience, and the nurses and everything, all this matters, finally. And of course, retinal detachment is also slightly common, the worse after the cataract surgery than a normal person. So, but today with the phacoemulsification and a very small wound, cut is 2.2 millimeters, chance of getting a retinal detachment after surgery is very much less, unless we had a capsule rupture and a complication. So detachment is very less with the phacoemulsification. Thank you. That's all. Any questions I can answer now, because I may not wait till the last lecture. Is it all that okay, Ranmini? Okay. Any questions I can answer?
The laser is put on the eye.
Pardon?
Is there any heating?
There is no laser here. We are doing at the moment phacoemulsification. So there is a certain amount of heating inside the eye, but the phaco, that all depends on the type of lens we are doing. If it's a mature cataract, we'll be
There's no
using.
effect on eye.
There's some amount of effect, but generally if you do the proper technique, and that won't affect the eye. But if you use a lot of power, there'll be much heating, and then of course it can damage the cornea, and that's how they get cornea edema and complications. They can have, but today's machines are so advanced, they have made it such a way that the heat is very much less compared to the older machines.
The patient complain of floater.
Yes.
Is it a common complication?
Yes, it's not a complication, it's a common complaint, but floaters are not due to cataract surgery. What happens is when they have a cataract, they can't see properly, they don't see floaters also so much. But moment you do the cataract surgery, everything is so clear, they start seeing the floaters, and floaters are vitreous opacities. Whereas inside the eye, in the middle of the eye, in the jelly, the floaters are moving. So those are actually the collagen fibers. The vitreous is made out of collagen fibers, and sometimes they separate, and you can see the line-like things and some opacity. They were there even before surgery. Maybe some people have it from the age of 30, 40. But moment you do the cataract, they start complaining about floaters more. So you have to explain to them. I, of course, have a leaflet. So I had no time to talk so much. I said, okay, go and read this. So it gives everything about how the floaters are formed and what are the bad, if you see flashes, what to do. All that is given in the leaflet. Most of the people have this floaters problem, but the floaters get worse because their vision gets better. Then they see the floaters. The floaters have nothing to do with the cataract, nothing to do with the surgery, unless they have diabetes and have vitreous hemorrhage or some other problem. But generally, floaters are vitreous opacities.
Is there any advice that you can give patients to prolong the development of cataract in a normal healthy person?
Yes, if it is a normal healthy person, but if it's a diabetic patient, you can tell them that you have to control your diabetes, otherwise you get a cataract early. But normal person, there is no way you can prevent a cataract. That is, you are getting your age, and depending on the different families also, some people get cataract early, some people don't get it till 80s. Of course, any injury, any other ocular surgery, all those can. And then the steroids. If you take steroids for any other problems like rheumatoid arthritis or other asthma or something, and then they are prone to get a cataract earlier than the other people. But absolutely normal, healthy person, then there is no way that we can stop cataract. There is no advice we can say to prevent a cataract. Of course, some people think ultraviolet light causes cataract, but it has not been proved. You can ask them to wear ultraviolet protection glasses if they are getting exposed to sunlight too much, more than an other person.
You said NSAIDs.
Yeah.
Oral or
No. NSI drops, yes.
antibiotics also drop?
Antibiotic drops, NSI drops, and the steroid drops. We don't give anything orally.
Charlie, it's not a question from you, it's a bit of a compliment for you. You
Yes.
have done my cataract surgery.
There are many people in this audience I can see, but I don't mention the names.
More than 20 years back.
Yes.
I have no problem.
I was in school at that time.
I'm quite okay. I should suggest, you did one for a long distance vision and other for the short vision.
So 91, I have done 30 years of surgery now. So
Thank you very much.
this is my 30th year. Okay. Thank you. One more question.
Is it recommended for cosmetic things?
Yes, sometimes, yes. There are people who have blind eye, but the cataract is so white and mature, they find it difficult because the people keep asking you, there is white, your eyes is white and all that. There are times I have removed that cataract for cosmetic reasons because the patient finds it difficult to face the people because they keep on asking your eye is white. But their vision may not be there. But still we remove the cataract. But at that time, sometimes we don't implant a lens if they are blind. So you just remove the cataract.
Thank you, sir, for that informative talk. Next, I would like to invite Dr. Pradeepa Sirivardhana, consultant ophthalmologist, National Eye Hospital, Colombo, to deliver her speech on acute red eye. Dr. Pradeepa.
Thank you, Kapila.
Just now to hand over the certificate of participation and the resources.
Good evening. Red dye is the commonest presentation to eye casualty. And there are varied causes for red dye, ranging from mild self-limiting conditions to conditions that can cause blindness. Red dye may initially present to a general practitioner or a primary care doctor who has to know which ones can be managed at the primary care level and which ones need urgent referral. So the outline of my lecture is going to be on recognition of common causes of red dye, adequate treatment at primary care level, and recognition and urgent referral of patients with high-risk conditions. I want to recap the anatomy of the eye because that will make the rest of my lecture easy. So the gross anatomy, the lids, then this is the sclera, which is covered by the transparent conjunctiva, then the transparent cornea through which you see the pupil and the iris, and the lids have the lacrimal puncta medially. And this is a longitudinal section of the eye. Posteriorly, there are the three coats, the sclera, the choroid, and the retina. Anteriorly, there's the ciliary body to which the transparent lens is attached. The ciliary body is responsible for producing aqueous humor, which provides nutrition to the two avascular structures of the eye, that is the lens and the cornea. The aqueous humor is secreted into this part called the posterior chamber of the eye. That is the part between the lens and the iris. And through the pupil enters the part called the anterior chamber. That is the part between the cornea and the iris, and leaves the iris through the anterior chamber angle. History taking of a patient with red dye is very important, because you have to exclude factors that indicate risk. The onset is usually acute. Location, whether it is unilateral or bilateral, is important because bilateral conditions are usually infections like conjunctivitis or allergies. Pain is a significant factor. Reduced vision or acute onset of halos around lights is significant. Photophobia is significant. History of contact lens wear should be excluded because these patients are more prone to develop corneal infections. Trauma is an emergency, and it's important to exclude medical history of autoimmune diseases. Now, symptoms like foreign body sensation, presence of a discharge, itching, burning sensation, lid edema, and history of contact with a patient with red dye generally indicate a benign condition. Even in a primary care setup, you can do an examination of the eye. You can have a Snellen chart in your setup. It could be either an illuminated Snellen chart or just the basic Snellen chart, because with a Snellen chart, you can assess the vision objectively. You need to use a pen light or a bright light to examine the eye. The pupil can be assessed for regularity, size, and the reaction to light. Presence of photophobia can be excluded during the examination. The cornea can be examined for clarity, haziness, or the presence of opacities. The distribution of redness will indicate the cause, because circumciliary redness or the redness distributed around the cornea usually indicates a sinister cause of red dye, whereas redness confined to the fornices, that is the pocket between the inside of the lid and the globe, usually indicate conjunctivitis, which may be either bacterial, viral, or even allergic. I have listed the common causes of red dye. Common benign causes include conjunctivitis, subconjunctival hemorrhage, blepharitis, styes, and dry eye disease. Less common and less serious ones are episcleritis and the corneal surfaces condition called, such as pingacula and pterygium. Less common but more serious ones include corneal ulcer, acute anterior uveitis or iritis, acute angle closure, scleritis, lens-induced glaucoma, and trauma. Viral conjunctivitis is the commonest cause of red dye. The most common cause is adenovirus. It has an acute onset. Initially, it is unilateral, but then later becomes bilateral. The discharge is usually watery so that the patient may not even notice the discharge. The patient just has discomfort. There's no photophobia or pain. And there may be a history of upper respiratory tract infection. And they will have a contact history most of the time. Now, the conjunctiva is often hyperemic, and the distribution is usually in this area, away from the limbal area. So follicles are usually seen on a slit lamp, but membranes and hemorrhages can be seen with a torch. And they usually have preauricular enlarged tender nodes, which generally indicates that it is a viral conjunctivitis. Now, there's no specific therapy because it is self-resolving, but it usually takes up to 2 weeks. It is important to advise proper hygiene and hand washing because this is very contagious. They need to avoid contact with others and stay away from school or home. And they benefit from cold compressors and artificial tears, and they should be asked not to rub the eye. Bacterial conjunctivitis can be caused by multiple organisms. And this also is contagious because it arises from direct contact with infected secretions. It has more of a subacute onset, and they have the same symptoms of viral conjunctivitis, but the discharge may be either mucopurulent or even frank purulent, and it may be bilateral. Now, they have lid crusting, which is there throughout the day, the conjunctival hyperemia, and they may have swelling of the lids and the conjunctiva. It is important to advise them on proper hygiene and hand washing because of the contagiousness of the disease. Now, even untreated, bacterial conjunctivitis can resolve after 10 days, but it is faster when they are prescribed antibiotics. The antibiotics have to be given QDS, 1 drop in each eye for a week, and usually they improve after the 5th day. Just to tell you a little about antibiotics that are used in the eye. Antibiotics are available as drops as well as ointments. So fusidine does not come in a bottle, it comes in a tube, but it is an aqueous suspension. It is fairly viscous, and patients find it difficult to instill it into the eye. Aminoglycosides that are available are gentamicin and tobramycin, fluoroquinolones, ciprofloxacin, ofloxacin, moxifloxacin, and gefloxacin. The latter two are 4th generations ones that are usually reserved for severe eye infections, so it is not advisable to use them. It is safer to use cipro and ofloxacin. Ointments are available for tobramycin, gefloxacin, and tetracycline. About instillation of drops and ointments. Now, a drop that is instilled into the eye can overflow. It can leave the eye through the lacrimal apparatus. So, to promote the retention of the drop within the eye, it is important to instill the eye into this pocket or the inferior fornix. The bottle, the tip of the bottle should not touch the lids or anything, and only 1 drop is instilled. The patient should be asked to keep the eye closed for about 5 minutes and press on this medial canthal area so that the drop will not drain out of the eye. Now, regarding ointments, Ointments are also instilled into this inferior fornix. A strip of ointment is squeezed in there, just like squeezing toothpaste onto a toothbrush. Now, these ones have a higher concentration of antibiotics, but because of the because they have oil base, they can cause blurring of vision. So they're recommended to use at night, and also recommended to use for styes and chalcesia. Now, coming to allergic conjunctivitis, 75% patients have associated atopy, while 2/3 have a family history of atopy. Now, they have severe itching and it is bilateral. The discharge is watery and there is chemosis or edema of the conjunctiva, which is worsened by rubbing. Other features are generally seen on the slit lamp. Now, these patients, important to exclude infection and important to confirm the allergen because they need to avoid contact with allergen. Usually in our setup, it is the dust. And the treatment depends on the severity. Cold compressors relieve the itching. They have to be advised to avoid exposure to the allergen. Topical or oral antihistamines and topical mast cell stabilizers are helpful. Artificial tears are also helpful because they dilute the chemical substances that cause irritation. Some patients may need a short course of steroids, so they need to be referred to an ophthalmologist. Subconjunctival hemorrhage is bleeding under the transparent conjunctiva, may follow trauma, or may follow the Valsalva maneuver, or may even be spontaneous, especially in the elderly or patients with diabetes and hypertension. The management is conservative, but the patient has to be told that it may take a week or two for the hemorrhage to resolve. Blepharitis is inflammation of the lids. It is a chronic eye condition, and these patients are prone to develop styes and other lid infections. So they have a gritty burning sensation and foreign body sensation. The lids are swollen and they have this crusting of the margins. Then they are generally sticky, itchy, and appear greasy, and they may have loss of lashes, and the lashes may turn gray. Now, because this is a chronic condition and therefore needs long-term commitment for treatment by the patient, it is important to educate the patient and counsel the patient. These patients benefit from warm compressors and lid scrubs. Dilute baby shampoo can be used for lid scrubs. 25% baby shampoo, that is 1 teaspoon of baby shampoo in 3 teaspoonfuls of warm water. And the cotton bud that is dipped in this solution can be used to scrub the lid margin. They need to clean at least twice a day. That is on waking in the morning and at bedtime, where the buildup is the worst. They benefit from topical antibiotic ointments, that is such as fusidic acid, and oral antibiotics. If they don't respond satisfactorily, important to refer to an ophthalmologist. Pterygium and pingicula. Pingicula is the initial stage of a pterygium, and this is the pterygium, which is the wing-shaped growth onto the cornea. They are caused by ultraviolet damage to the surface of the eye. Because these disturb the tear film, they can cause irritation and burning sensation and foreign body sensation. Now, in a pterygium like this, which comes to the visual axis and distorts the cornea, there can be visual issues. So these patients benefit from artificial tears, and if the pterygium is large, it needs surgical excision. Bacterial infections of lash follicles and lid glands, such as styes and chalcesia, may be accompanied by red dye. They benefit with antibiotic ointments and oral antibiotics. Episcleritis is another condition. It generally causes redness that is on the bulbar conjunctiva or the globe part. Now, this is there's inflammation of the episcleral tissue. These patients just have mild discomfort and tearing, and sometimes it is self-limiting, but they may benefit from topical steroids, topical NSAIDs, or even systemic NSAIDs. Episcleritis has to be differentiated from this more sinister disorder, which is scleritis. Similar presentation, but here the redness is more intense. This is granulomatous inflammation of the sclera, and 45% of cases are associated with the connective tissue disorder like the rheumatoid arthritis. Now, in a patient with a diagnosed connective tissue disorder, appearance of scleritis usually indicates that the prognosis for the disorder is poor. Now, this can cause scleral thinning and melting and rupture. So, early management is important. So, this shows active scleritis. This is resolved scleritis. Here, these dark areas are the thin sclera showing the underlying choroid. Now, these patients have severe pain. They often say that it is a boring type of pain which keeps them up from sleep, which is disturbing sleep. They can have photophobia and tearing, and there may be history of autoimmune disease. They need to be treated with immunosuppressives and systemic steroids, and they benefit from early referral. Corneal ulcer or microbial keratitis is common following trauma in patients who wear contact lenses, especially if their contact lens hygiene is not satisfactory. Patients with dry eye, because normal tear film has antibacterial substances, and patients who are deficient in this, those patients who have dry eye are deficient in these substances. Then corneal anesthesia and exposure keratopathy, as in patients who have facial palsy or patients who have severe proptosis. Urgent intervention is necessary because they need frequent antibiotics or antifungals. Now, usually in our setup, the infections that follow agricultural trauma are usually due to multiple organisms, such as bacteria and fungi. So, if they don't respond to treatment, they may need even a corneal graft like this. Acute tangle closure is a condition that occurs in people who are predisposed. Now, I have this diagram. This is the normal person. This is a person who is prone to develop acute tangle closure, because here the distance between the iris and the cornea is less, and when the pupil dilates, it tends to block the access of the aqueous humor to this angle, and there's an acute sudden increase of the intraocular pressure. So this presents as acute onset painful red dye with blurred vision and acute onset of seeing halos around lights. Now, if you examine their eye, their cornea is not clear, the cornea is hazy, and usually the pupil is fixed and dilated. And sometimes they also have nausea and vomiting, and there's a high chance that they may get referred to a medical unit if their eye is not looked into. And these patients also have this redness more concentrated around the limbal area. Acute anterior uveitis or iritis is a unilateral condition with variable visual loss. It is inflammation of the iris and maybe the ciliary body, and associated with infectious or systemic immune-mediated diseases. And these patients also have the redness concentrated around the limbal area. And because their pupil is adherent to the front of the lens, they tend to have an irregular pupil, which responds poorly to light. Now, lens-induced glaucomas, Dr. Pathirana showed you the very mature cataract. If a very mature cataract is ignored, that tends to cause acute increase in the intraocular pressure by various mechanisms, and they cause painful red dye. And if you examine their eye, they have the redness around the limbus, hazy cornea, and this mature cataract. So they need to be referred urgently to bring the intraocular pressure down. And after the control of intraocular pressure and the inflammation, they need to have early cataract surgery. Trauma is an ophthalmic emergency. Dr. Mangala Gamage will be dealing with this. Any patient given a history of trauma has to be referred as early as possible. Now, red flags in a patient with red eye include reduced visual acuity, blurred vision with photophobia, deep pain in the eye, not just surface irritation as with conjunctivitis, absent or sluggish pupil response or an irregular pupil, and haziness or opacities in the cornea, and also a history of trauma. In conclusion, red eye is a very important ophthalmological presentation. The main target is to differentiate emergencies that need urgent attention. Good history taking is essential. Red flag symptoms and signs should be looked out for. Routine, thorough examination is a must, and the iris, cornea, sclera, conjunctiva, and lids have to be examined in every case. Thank you.
Thank you, Dr. Pradeepa. Thank you for that very illustrative lecture. Next, I would like to invite Dr. Mudita Kulatunga, Senior Consultant Ophthalmologist, National Hospital, Colombo, to deliver a lecture on glaucoma, the silent steal of vision. Madam.
Thank you very much. Good evening, everyone. I would like to thank the College of Eye Surgeons Ophthalmologists for inviting me to give this speech on glaucoma. Now, as primary care physicians, you all need to know that the glaucoma that we are talking about is primary open angle glaucoma, which is the one which has no symptoms, absolutely no symptoms in early stages. You and I can have glaucoma without knowing. And also, with the advancing age, incidence also rises. Now, regarding glaucoma, what is glaucoma? It's an optic neuropathy. It has to be progressive. For you to diagnose glaucoma, the neuropathy should be progressive. That is, if you don't do anything this year and reimage the nerve next year, the damage should be shown. That's it's a progressive thing. And then you get gradual loss of vision and finally eventual blindness. Now, how big is this problem? About like from the studies that we did, we don't have exact figures for Sri Lanka, but I did some certain hospital-based studies in 2009 onwards, which showed about 12% of people might be having this type of glaucoma in Sri Lanka. Altogether, like the glaucoma incidence in Sri Lanka might be about 12% of population. But what we know is the figures for Southeast Asia. Now, it's more common over the 40 years. And with advancing age, the incidence increases. Now, world blindness also similar to that. About 12 to 14% will have glaucoma. So our country situation is similar. So about 12% of people means a lot of people getting involved. The morbidity is more than the blindness actually. So who are the people who are more vulnerable? If you have a family history of glaucoma, if you have someone in your family, then it's very likely that you have to get the screening done every year. Normally, we say if you're normal, get it done every 3 years or 4 years. But if you have someone in your family, get it done every year, irrespective of your age. Otherwise, you can do at 40 or above. And also people who has diabetes are more prone to get. Then if you're on any systemic steroids, the chances are more. And also short-sightedness like myopia, trauma to the eye, and age are more sort of people with the where you have to think about. Now, if you don't treat, the important thing is if you diagnose early and treat, they will have near normal vision. So the important thing is to diagnose early. So because of the symptomless nature, the diagnosis is also difficult because people don't come to us. And unless you pass the message to community, the important thing is to screen them or check them when they get their glasses, whether they have glaucoma. So if someone says to the doctor, can you check whether I have glaucoma, then very often the ophthalmologist will now always check for glaucoma when they come for something else. But even if as primary care physicians, if you all can tell, it's very important that you check it, because unless you check it, you don't know. Early stages, you never know. Now this picture you think it's a normal visual field, but this can be early stages of glaucoma. A patient can see the focus of interest very clearly up until late stages. So visual acuity is not a feature that you will look for. So the normal visual acuity is continuing to have until the last stages of the disease. It's something like this. Now here also the fields are lost, but patient won't know because of the nature of the disease. You see the focus of interest always. So this is late stage of glaucoma. And there are different types of glaucomas, but we are interested in primary open angle glaucoma for you all to know, because that is the disease which has no symptoms. Now, why do people get glaucoma? It's just that the ciliary body produce certain amount of aqueous, and this aqueous is drained out of the eye. So the eye is like it's also a homeostatic system where this fluid is kept within a normal balance. So the amount of produced fluid and the amount that is gone out of the eye is maintained within a constant figure. That's how the pressure is maintained between 12 and 18 millimeter G. If you see how the fluid goes out of the eye, that's the system. So if you see why people get glaucoma is at this point, where the Schlem's canal, where the cursor is the Schlem's canal, there is blockage. So normally the constant amount is produced, but the outflow is reduced. Very often there is some blockage in that point. So the pressure goes up. So these are ways that the fluid goes out of the eye. A is the conventional way. There are other ways also. Now this is in angle closure, as Dr. Impa said, you get the iris going and blocking the angle, which is an acute condition, and patient will present with red eye, so diagnosis is early. But what is the difficulty in diagnosing primary open angle glaucoma? Because it has no symptoms. By the time you measure the fields, 40% of the nerve is damaged. By the time you get the field effect, 40% of the nerve is gone. And this is a permanent damage. That's why we need something to detect glaucoma before the fields are lost. So how do you check? We have to check the pressure. Pressure is a cardinal thing. So the Goldman tonometry is the gold standard. But there are other ways where we can check the pressure in the fields also. This is how we check in the theater, sometimes in children. This is a puff tonometry which can be used to check pressure in the field. This is also a puff type. Tonopen is also a mobile, portable tonometer. However, the pressure check is the most crucial because the only way you can detect is one is the pressure, the other thing is a disc appearance. Slit lamp is used, we use the slit lamp, but we had a program where we trained the general practitioners with the ophthalmoscope. Now, unfortunately, because of the COVID, we can't allow people to use the direct ophthalmoscope. So that has become a problem in detecting glaucoma, but at least the fundal photograph is a good alternative. This is how we check the pressure. Now, I want to show how difficult to detect glaucoma even for ophthalmologists. Now, if it is like this normal disc, and the second one very huge cup ratio to disc ratio only we check. Now, the cup ratio is high in this case, but this is small cup. But so this one, of course, it's a obvious glaucomatous change, obviously normal, but you don't get very clear-cut cases like this in the practice. So disc appearance can vary in individual. It's like your thumbprint or the skin crease. So it's different. The disc is very unique for some people. Therefore, disc cup ratio to disc ratio is also can vary in normal people. So if you see, these two are normal discs, but one is a bigger disc and bigger cup. The other one is a smaller disc and smaller cup. So you need to recognize, sometimes we mistakenly recognize this as a glaucoma disc, but it's not, it's a normal disc. Now this one, it's a congenital disc defect. Optic disc, the pit. So this looks like glaucomatous, but this is a normal disc. Normal in the sense it has a congenital defect. So now if you look at this disc, this is a normal looking disc, but it has glaucoma. If you see the nerve fibrillary defect, this is early stages of glaucoma. There is a nerve fibrillary defect. See, even for us, it's a very confusing thing to diagnose glaucoma. So there are different types of, now this is again normal looking disc, but this is glaucoma because there is a nerve fibrillary defect. So for us, our eyes are trained to look at this, but for general practitioners, if you see something like this, but of course, if you're allowed to use the direct ophthalmoscope in future, you need to detect these as glaucomatous discs or suspicious discs. This again glaucomatous, but it looks normal. Now, if you see this disc, it has a splinter hemorrhage, small hemorrhage, which even this one, which is a diagnostic of glaucoma. So this drawing again, how the glaucomatous cupping progresses. So likewise, now these ones, again, we used to give for the doctors, general doctors, to recognize the cup disc ratio. So there was a program that we gave these cards to the doctors. Now, again, organizing a workshop for general practitioners was a bit difficult because most of the general practitioners are the doctors who are working in the hospitals. In the morning, they work in the afternoon. So the general practitioners per se who have practice in the morning, it's very difficult for them to gather for our program. What we realized was it was difficult for us to gather the general practitioners. Now this again a similar thing to show how difficult it is to detect glaucoma. Now this is a field where we check the visual fields, perimetry. Now by the time you lose about perimetry about like this, more than 40% of the nerve is gone. So it's not a good thing. If you look at this disc, in 2002, it's like this. 2003, very tiny defect. 2005, you see a splinter hemorrhage and another like slight increase. So you can see how slowly this defect is progressing. Sometimes unless you monitor, you can miss these cases. So why is it important for us to know all this about? Because clinical detection is not straightforward even for the ophthalmologist. That's why the imaging of the optic nerve is very, very important in early detection. So we have the tomograms, OCT, ocular coherent tomogram, and then we have analysis of the optic nerve head, and now we have angiogram. This OCT angiogram is where you don't inject the dye, but you can map the blood vessels of the optic nerve. So it's very important because it's a non-invasive. You don't have to inject the dye. So where you can detect glaucoma early. So these are the pictures where you can detect pre-perimetric glaucoma before the fields are lost. Now, recent evaluations or recent studies done on early detection, and they have found that artificial intelligence algorithms in ophthalmology has improved the understanding of these retinal pathologies. If you see this picture, it gives a heat map. That is in the normal, this is called deep learning network. They have these heat maps which show normal looking optic disc, but shows a deep, when you image it with the heat maps, you can detect preclinical glaucoma. So it's very important to diagnose these cases very early. So these heat maps help. Again, another thing is optic nerve head segmentation. That is also a deep learning thing based on the artificial intelligence, where you can detect glaucoma early. This is a baseline thing. This is the enhanced image. Again, the segmentation also helps. So all these are in detecting early glaucoma preclinical. That's before the clinician can see clinically. So this management-wise, if you think, mainly it's a medical management. So the prostaglandin analogs is the most important drug that we use. The important thing about this drug is it's a once-a-day use. So you can use it in the night, but the difficulty is it has a lot of surface side effects like redness and tearing when you use the drug. Other drugs are also have been used, but carbonic anhydrase topical preparation is available right now, which has to be used twice or 3 times. So the compliance is poor, therefore. But prostaglandin analog is a better drug. Now, this is the medical management that we should follow. And now, because these drops are very difficult for people to use, they have tried to sort of change the surface of the drug. Like to include it into a gel or neosome, or include it in the drug into a liposome, so that the tolerability is increased and the penetration is increased, and also the use as a nanoparticle. All these are to help increase the absorption or maintain the drug inside the eye. These are emerging, treatment trials that they have done with different coatings of the drug so that the patient will tolerate it better. So various mechanisms of to increase the corneal permeation. Again, the polymers, cross-link polymers are used with the drug. Now, the most important thing is if you treat, again, the hypertensives, you treat hypertension patients, we also want, like those days the teaching is you have to reduce the pressure. But if you reduce the pressure too much, in a glaucoma patient, their ocular perfusion pressure will be reduced. If you reduce the blood pressure, the effective ocular perfusion pressure will be reduced, especially in the night, which is called the nocturnal dip in blood pressure. So if you do that, the glaucoma will progress. Irrespective of the pressure control in the eye, the glaucoma will progress. So the important thing for you all to know is that controlling blood pressure in the night the night dose should be maintained when you know the 24-hour blood pressure monitoring is done, when you are aware of what is happening in the night. So, because otherwise in glaucoma patients, you can get nocturnal dip, which will reduce the ocular blood flow and which will make the glaucoma worse. So it's very important over enthusiastic treatment of hypertension and also reduced pressure in the night should be avoided. And also regarding the medical management, you need to find out from the patient whether they have sleep apnea. Sleep apnea also is known to cause progression of glaucoma in these patients. And also like deviation, like if you try to sort of, the sleep studies and things are very important in this group of people, the glaucoma people, those who are on treatment. So you have to talk to the patient and their spouses and find out whether they have in the sleep disturbances in the night. Sleep studies are very important in this group. Now, surgical, other than the medical management, the surgical management is generally the gold standard is trabeculectomy, but there are new devices like a shunt, like for cardiac shunts, we have a shunt for the trabeculectomy site here to prevent the drainage problem. So you put a shunt. These are different shunts available right now. But these shunts don't reduce pressure too much. Like say moderate glaucomas can be treated like this. So important thing is follow-up studies, family screening is very important, and then counseling for these patients and their relatives, the requirement for the lifelong treatment. Now this take home message is diagnosis is not straightforward even for ophthalmologists. Primary care setting over treatment of hypertension should be avoided. Disc evaluation should be done properly. Actually, it will be difficult for the general practitioner, but primary care setting, you can do direct ophthalmoscopy if permissible, like the COVID situation is giving permission, but then otherwise you can do direct fundus photography. Fundus photography is a very effective way of checking the disc appearance. Then the primary emphasis is diagnosis of imaging. Imaging is the key thing in diagnosing. Then owing to the silent nature, so patients don't come to us. So therefore, it's very important when you meet your patients to tell them, look, if you're over 40, if you're going for glasses, get your eyes examined for glaucoma. Unless they examine like that, we will miss it. Because patients, unless you all tell the patients, look, this is an asymptomatic disease, you get it checked. Then public education is very important. Now we have eye surgeons everywhere now. This is a slide I did in 2009 where we didn't have so many eye surgeons at that time. Now we have more. And therefore you can refer to the ophthalmologist and also keep the people educated about this disease, which will definitely cause blindness if we miss it. So it will be a permanent blindness. Thank you very much.
If a person has normal eyesight, no hypertension, how does one detect glaucoma in that person? Because you say it's a silent disease.
Yes. Yeah, that's right. Now, that's a very good question. Because now anyone who is over 40 will go to get glasses. That is the time we aim at diagnosing or looking at the optic discs to check their eye pressure and look at the optic disc.
Is the vision normal?
Yeah. Now in glaucoma, the vision will be normal until last stage.
So how do you detect it?
We are and that is why it's important, because patients think that I can see, I can't have any glaucoma because I can see well. It is the key thing to take is like when your vision is normal only you have to see, then only the visual field you can protect. Then we check the eye pressure and look at the optic disc. Then we suspect if the pressure is slightly high towards the 18 or something, the disc is cupped, slightly cupped. But if you do the visual fields will be normal. So we want to diagnose this is pre-perimetric glaucoma before the fields are lost.
But for a person who is not an eye surgeon, I think it is difficult to assess the size of the optic compared to optic.
No, you can't.
Yeah, so in that case, I think you would recommend a person to go to an eye surgeon.
It's a counseling thing that you all can do. It's a kind of a counseling thing that you all can do. And what we do is ask the optometrist to keep eye pressure measurements, like keep doing the eye pressure measurements when they come for glasses. So optometrists are educated that way. The GPs are educated to tell the patients, look, you need to go and get your eyes examined. Just don't go to the spectacle shop and buy the spectacles and use it. So that's the time you have to refer them.
Madam, you were telling about the fundal photographs.
Yeah.
Is it available and how expensive it is? So would you recommend that for GPs to do it on a regular basis?
Yeah, not on regular basis, because for every, it will be about 1,000 rupees, and it's available. It's available only in few places like eye hospital. Of course, we generally don't do for private sector. It's available in Vision Care. No, it's available in Navaloka, then Asiri Central, this CDM hospital, and so many hospitals available. It's about 1,000 rupees.
How sensitive is that as a diagnostic instrument for chronic glaucoma?
For glaucoma, red-free optic disc photo and just a photograph of the optic disc. This is not the glaucoma, the diabetic screening thing. Diabetic screening photo is different. It's quite, actually, they have found it's quite safe. Like if someone is with experience is reading these photos, they were able to at least suspect glaucoma in more than 50% of patients. There was a study done on this. So I think if you, because you can't go close to see the disc now these days, you can't use the direct ophthalmoscope. So the only way is if there is a family history of glaucoma, you can ask their family people to get the glaucoma screening done. Glaucoma screening is available as the whole thing, the package, the screening is available in most places. We also do it, but places like Vision Care, they just do the thing and then refer the patient. Central corneal thickness. Other thing is the thickness of the cornea. That also helps to diagnose. Right, thank you.
Thank you, madam, for that very informative talk on glaucoma. Now I would like to invite Dr. Kapila Bandhu Tilaka, consultant vitreoretinal surgeon of Eye Hospital Colombo, to deliver a very important lecture on diabetes and the eye.
Thank you, Madam President. Dr. Muthakuladingo was talking about the one cause of preventable blindness. One major cause of preventable blindness is diabetes. And I'm going to talk on diabetes and how we are affected with diabetes. I think we have a collective responsibility. We means ophthalmologists and physicians have a collective responsibility to prevent this, this problem. So if you check the gravity of this problem, you can see that this is everywhere. The diabetes is everywhere. 415 million adults with diabetes worldwide. And if you project a little bit, 2015, 415 million. Of this 415 million, you see that 45 million are having vision-threatening diabetic retinopathy. 2040, in another 20 years, what's the situation? We will experience 642 million. Of this, 70 million are having vision-threatening this problem. Almost 80% of diabetic cases occur in low and middle income countries. The point is, we are in this group. That's the problem. 35% of cases are undiagnosed in high income countries, while we are 50% in low and middle income countries, they are undiagnosed. So this is a situation. More than 93 million people suffer from some sort of eye damage due to diabetes. So, but what is the impact of this problem? The impact is, you can tell anything. from psychological, physical, work-related, loss of independence, and lot of things. All basically, if you think the patient is affected, family is affected, society is affected. That's the problem of this thing. So what will happen in diabetic eye disease? If you're talking about diabetic eye disease, it starts from where we were talking about cataract, from cataract to external ocular, from external ocular muscles, glaucoma, everything will be involved in this problem. So the complications like diabetic retinopathy is the most common eye problem. We'll talk about it. Then the specific to progression of the ocular disease, like cataract and sometimes rubeosis of iris, that is a new vessel formation and things like will happen. Then the non-specific recognized associations like glaucoma, what we were talking about, then retinal vein occlusion, ischemic optic neuropathy, and many other causes also can be taken as complications of this problem. So ocular effects of diabetes will affect all these structures. I'm not going to pinpoint each and everything. But we'll start. Dr. Pradeepa Srivastava was talking about the infections of the eye, the blepharitis, and the other things. That this photograph you can see the chalazion, the infection of the lid. These are common with these people. These people will come to you telling that they are. I'm not talking about the conjunctivitis, but these will come and tell you with a lot of problems like they have irritation of eye, they have loss of lashes and things like that. In addition to that, simple things like even they have tear problems, because tears, you know, that is not only the water, it can be mucus and a lot of things. So with these diabetes patients, some glands are not working. So sometimes mucus glands are not working. So it is the tear is mainly watery. So they will come and tell you that a lot of the irritation and problems like that. It's like that. So cornea, you know that diabetic is affecting your nerves. So they can get ulcers like this. Why is that? Because they will lose their corneal sensation. When they lose their corneal sensation, there's a tendency to get more and more trauma. In addition to that, spontaneously also because of dryness, they can get ulcers like this. The greenish color one is ulcer, which is, we have stained it. This is a viral ulcer. You can see the pattern, geographical pattern. This is a bacterial ulcer. These are common. So the refractive errors. We all are having refractive errors, but I'm not going to talk about these refractive errors. But suddenly somebody will come and tell you, I was able to see very well, but in the last few days, I'm unable to see. So this may be, this is the point, or this is the situation where you diagnose this patient has diabetes, not diabetic retinopathy, but diabetes. Because what will happen, sometimes they have a myopic shift. What is myopic shift? What can happen? So collection of the sugar alcohol sorbitate in the lens due to the increased aldose reductase activity, the lens starts swell. When lens starts swell, so what can happen? The lens swells, refractive power increases, and image forms in front of the retina. So it's a myopic shift. So that can happen. The patient will come and tell us that suddenly I lose the vision last few days. So same way, when you control the sugar, then now you identify diabetes and you control. Then again, they will come and tell you that I have a problem with the vision again. Why? There's a hypometropic shift because there's a decreased osmotic pressure. The refractive index of the lens goes down, the power goes down, and image form behind the lens, behind the retina. So cataract we were talking about. The diabetic cataract, you can see that mature cataract what Dr. Salipatran was shown you, but the lower down one is the problematic one. These are the cataracts which we will see in young people who are having diabetes. The problem of this cataract, as Dr. Patran told us, usually they have a reasonably good vision, but they are problematic, or they will come and tell us that I'm unable to drive in the night, or when I go out in the daytime, very difficult to see. Why is that? When the pupil, you see that this cataract is at the center. So when the pupil is small, the light goes through that area. Or in the night, they will get a lot of glare. So that is disabling cataracts. That's the problem in these people. Then I will select two cases. These are real cases which referred to me last week. The first one is 32-year-old male. You see the diabetic diagnosed 12 years back, HbA1c 10.5. So you can think of the control. He was never seen by eye surgeon, and he didn't tell me the proper history, but he told me that he had a sudden decrease of vision. I felt like there's something floating in my field. This is his right eye. Can you see what you can see? I don't know whether it is clear, but you can't see fundus clearly. You can see something is covering. This is blood. Okay, this is the left eye. If the picture is clear, you can see that red dots, and sometimes these are not that clear. These are new blood vessels. This is a 32-year-old person. He has never been treated. You can't see laser scars or anything here. The other patient, 47-year-old female. This was also the same. She was diagnosed 5 years, diabetic with 5 years. I don't think it is a 5 years. She has been seen 5 years back, but maybe having for a long time. HbA1c 11.3. You see, no, her right eye, you can see these are not new normal vessels. These are abnormal. You can see these are proliferated blood vessels, the right eye. Left eye, this is the hemorrhages because of the rupture. This is a proliferative diabetic retinopathy. So this is the problem. This is the major problem with the diabetic retinopathy. Diabetic retinopathy is the most important ocular complication of diabetes. The prevalence of diabetic retinopathy of any severity in the diabetic population is about 30%, and prevalence of blindness due to DR is 5%. Can you believe that? So, risk of diabetic retinopathy. Everybody is risking, there are some having more risk. Yes, there are some risk factors. I'm not going to discuss all these things, but the people who are coming to us, we have to think about these risk factors, because some are having more, some are in higher risk level than the others. One thing is age, the duration of diabetes, and the other factors like hypertension, cholesterol, these will contribute. In addition to that, obesity, smoking, then other systemic eye diseases, systemic diseases like kidney diseases and those, they are also in this high risk group. So why we are getting this diabetic retinopathy? Little bit of anatomy of the retina. You see that the retina, this is the cross section of the retina. You can see retina, there are a lot of blood vessels in this retina. So if you do a histological analysis of this retina, this is the diabetic and this is the normal person. This retina, if you check their endothelium, they have their blood vessels. These blood vessels, there are certain histological changes. The endothelial cells are less and they are more sticky, and the pericytes number is less. So what can happen? So because of these things, these blood vessels gradually become more leaky, and because endothelial problems, these endothelial cells, surfaces become more sticky. Because of that, we can explain everything. So because of the stickiness, you can get a plugs, platelet plugs, cholesterol plugs, and they can get a occlusion and occluded blood vessels. And at the same time, you can get a lot of leakage. So because of this thing will happen. You can get a swelling. Because of occlusion, you can get a ischemia and exudates, leakage of the fluid. So everything after this can be explained with these basic things. So the clinical features of diabetic retinopathy, all this can be explained. Microaneurysms, hemorrhages, hard exudates, these are leakage of the lipids, the swelling, cottonwool spots, these are the ischemia of the nerve fibers. Then there's some new vessel formation. Because of the ischemia, the retina, the ischemic areas release a lot of agents. Because of these agents, the normal blood vessels start proliferate with formation of new blood vessels, and the problem is new blood vessels. These new blood vessels are not normal. They grow in abnormal planes and they rupture. So because of all these things, we stage the diabetic retinopathy for our management purpose and follow-up purpose. From non-proliferative diabetic retinopathy to proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy also we divide into mild, moderate, severe, and proliferative diabetic retinopathy also high risk and less high risk. Not the no risk, but it's a less high risk. Okay, so we were talking about the risk factors. What do you think about the duration of the diabetic retinopathy? This is the situation. About presentation, type 2 diabetes, about 5% we have seen the diabetic retinopathy. When it comes to the, you can see that more than about 20 years, it was almost, we have to expect 100%, some sort of a diabetic retinopathy in these patients. So duration matters a lot. So when it comes to the classification again, non-proliferative diabetic retinopathy, I'm not going to discuss this boring lot, but when it comes to non-proliferative diabetic retinopathy, actually in any level, we can see these patients because we can just dilate the patient, even ophthalmoscope, we can see little bit of like a dots like microaneurysms, 1 or 2 dots. Then we can take them as mild non-proliferative diabetic retinopathy. You don't have to bother. You can control them. You have to control them medically. Risk factors, hypertension, cholesterol has to be controlled, and we can review them in 1 to 2 years. 1 year. Then when it comes to moderate, the changes are more. You can see that more hard exudates and more hemorrhages. So these people need a little bit attention about their risk factors. So we have to, in maybe 6 months, we have, 1 year, we have to screen them possibly and to be done by ophthalmologists. The severe stage, severe non-proliferative diabetic retinopathy is high risk because there's a rule we are following. They have hemorrhages in everywhere, and there's a venous changes, and in addition to that, intraretinal microvascular abnormalities. You can see some sort of like loops like things in the retinal layers. They are not coming out of the retina, but you can see in the retina. So these things also can be seen by the ophthalmoscope. So this is a severe non-proliferative diabetic retinopathy because no proliferation of the vessels. But the thing is, this is very important because these people quickly can become a proliferative diabetic retinopathy. That's the problem. So how do we manage them? We see them very frequently. And at the same time, if you are not sure about their follow-up, then what we do is we treat them as proliferative diabetic retinopathy, like we do the laser. At the same time, we talk with the physician to control their medical problems aggressively. Otherwise, we will not be able to stop this level. So when it comes to proliferative diabetic retinopathy, you know that name says proliferation means new blood vessel formation. So we saw this, that patients, you remember, new blood vessels grow in these patients. So this is a high risk situation. So we'll see new blood vessel formation. At the same time, sometimes we hemorrhages. This is a very dangerous situation because now you see that here the new blood vessels, you can see that at the disc and some other blood vessels in the peripheral area. So these people can progress into very bad situation. So other thing, so we were talking about the diabetic retinopathy of everywhere, but do they present to us? The problem is diabetic retinopathy, especially even low risk proliferative diabetic retinopathy patient may not come. That's what happened to that people because their vision is good. Why? Because the macula is sometimes not affected. But when there is something like this is the macula area where you get the fine vision. When this happens, patient definitely come and see us because there's a reduction of fine vision. They will not be able to read. So the previous, we were talking about the OCT. OCT is a cross-section of the retina which we can take, and this is available in everywhere, in almost not everywhere, but major centers available, this scan. So this is the cross-section of the retina. We've gone through this area. You see that, we'll go through to the next slide. This is the normal retina of the man. But when there is a swelling, the fluid collection, it is like this. So the vision goes down. That is called maculopathy. These people will come to us. So it is easy. So anyway, now you see that diabetic retinopathy sometimes may not present as vision reduction. When do they present? They present in two situations. One is caused by maculopathy, what we were talking about previously. When there's a maculopathy, even in the early stages, they will come and see you. The other stage is we saw two patients. They had no maculopathy or less maculopathy. They are having a vitreous hemorrhage or tractional detail, something like that. They will come and see us because their vision suddenly goes. So these are the vitreous hemorrhages. We have seen that these type of patient. You can see that this is a hemorrhage filled and this is almost full with blood. So what is tractional retinal detachment? These new blood vessels grows everywhere. Over the retina, when they grow in the retina, what can happen? They will grow and onto the vitreous, the cavity, then they cause some sort of attraction and retina comes out. That is called tractional retinal detachment. So when it comes to this stage, situation is very bad. So strategies of diabetic retinopathy management, you have to play a very big role, not by us. The systemic treatment is very important because glucose, blood sugar, and lipids, we have to control aggressively. The ocular treatment wise, we can do some certain things. But if you summarize what we can do, general management, from education to lifestyle changes to management of the complications of diabetes, everything matters a lot. We can't alone, as ophthalmologists, we can't manage this alone. Definitely we need your support. The physician support is need. Otherwise, whatever the surgery, what I do, the most complicated, even I do a most complicated retinal surgery for these people, the following day, if their sugar goes up, no point in point, because definitely I will fail. That's the main problem. So when it comes to the ophthalmological management of these patients, the medical management still play a big role. Then some patients like mild diabetic retinopathy, it is not my management, it's your management, because you will control the sugar, patient will settle. That's the observation period. But when it comes to the severe non-proliferative or early proliferative diabetic retinopathy, like stages, we do the laser. What is mean by laser? And anti-VEGF, we use some injections like things. So, we'll talk about this a little bit. The medical treatment wise, glucose control is very important. And why I am telling it is important, you can see that this is the trial DCCT, which is a major trial which was done. And you can see that this is the diabetic retinopathy. When HbA1c goes up, diabetic retinopathy, eye is the one most affected. You can see that the importance of the sugar control. So glucose control remain critical. You can see that there's two sides. Intensive glucose control reduces the onset of diabetic retinopathy by 75%, while it reduces the progression of disease by 50%. So you see that it is not our management, it is your management. So we can control them. So when I going to screen these patients, usually type 1 diabetes, usually we diagnose them early. So after 5 is adequate, but type 2 as soon as possible, because we don't know when it was started. That's why. When it comes to the gestational diabetes, theoretically, if it is a first pregnancy, we don't have to screen. Theoretically, but practically, the problem is most of the gestational diabetes are not gestational diabetes. They had diabetes and we diagnose them at the pregnancy. That's the problem. That's why we recommend to screen them. So normally, annually normal diabetes, we screen them. Mild NPD are even 1 year, moderate, maybe 6 months to 1 year, we decide by the ophthalmologist. Severe, every 4 months or more frequently. When it comes to proliferative diabetic retinopathy, frequency is more. So blood pressure control is very important. The tight BP control associated with low risk. So it has shown. And risk factors, when we see, you see that if you like a summary of the risk factors, you see that HbA1c, blood pressure, and cholesterol play a major role. So we were talking about the laser therapy. What is mean by laser therapy? Because the patient will come and ask from you. Laser therapy is actually simple terms. We are using laser. It's some sort of like energy way of delivering the energy. We use a laser to simple terms. We burn the certain area which are ischemic. So why we want to destroy or burn these ischemic areas? There are two things. One thing is we reducing the ischemic areas by basically destroying them. So the ischemic areas usually tend to release some agents like vascular endothelial growth factors, because when you check these diabetic patients, you can see that high level of vascular endothelial growth factors. That is the problem with this. So we reduce the laser, and in maculopathy sometimes we use a laser to block some leaks also. And in addition to that, laser also indirectly increase to release some favorable factors. So we use the laser in mainly proliferative diabetic retinopathy. Maculopathy is what we were talking about, and sometimes severe non-proliferative diabetic retinopathy as well. So this is the laser dye. You can see that these are the laser marks we can use these type of measures to do laser. It is it's OPD procedure, and usually it is not a painful procedure. So you can see that here, before the laser, you can see these are new blood vessels like a network. You can see this is after the laser, the blood vessels gradually shrinks. So diabetic, the maculopathy, we do a laser to, now you can see before the laser, you can see that hard exudates, and here you can't see, that's gradually the radius, not always, but sometimes. So the other thing is the patient, we were talking about the injections now. There are a lot of patients, they will come and talk to you about the injections which are given to eye. Why we are giving injections to eye in these diabetic patients? One thing is, I was talking about a vascular endothelial growth factor. So these people, they have a high VEGF level. VEGF level, when it is high, it causes two problems. As I told you, one thing is leaking of the blood vessels. One thing is increased proliferation of the new blood vessels. To stop that, we are using these type of injection, which all of these are available in Sri Lanka, and we are injecting according to the patient, according to the situation, not everybody. And in addition to that, we are using dexamethasone and triamcinolone as steroids. We have even dexamethasone implants in the country, which we use in some types of chronic macular edemas, and they respond very well for this type of treatments. So this is how we give injection. We just put a drop and we give injections like this. So these antivascular endothelial growth factors and steroids will be given like this. It's a surgical. We do it in a sterile environment. So I was talking about the proliferative diabetic retinal tractional detachment. So where are they going to end? They are going to end in this type of major surgery. These surgeries are time consuming, costly. Even a government sector or private sector, they are costly, and we have to use a sophisticated instruments. They are not available everywhere. At the same time, there is surgeons and the supporting staff. There are problems with this lack of the country. So this is the problem with the, so this is after the vitrectomy. You remember that patient I planned for a surgery, that remember the young chap who is having hemorrhage. So this is not the same case, but it was not done yet. But this one, you can see that this is before the surgery, and this is the after surgery and after the vitrectomy. So these are the main problem with the diabetic retinopathy. We were talking about specific problems due to diabetes, which is happening to the eye. In addition to that non-specific problem, which we were talking about the glaucoma, some vein occlusions and things. So you can see sometimes these type of vein occlusions are also common with these patients. This is different from diabetic retinopathy. You can see that this one, you see that hemorrhages in this area. So that is because this upper part of the vein is blocked. This is common in diabetes and cholesterol and hypertensive patient. Here, the vein occlusion is everywhere. So, but these patients will present with sudden loss of vision or sudden loss of field. These are will, and you can ophthalmoscope, you can see this pattern nicely, because usually one eye is involved, other eye is not. Diabetic retinopathy, usually both eyes are little bit asymmetry, but usually involved. So, but when it comes to vein occlusions, there's asymmetry, because most of the time one eye present with one eye problem. So, and the location and the way it is been, we can diagnose, and their presentation is sudden. So, the key learning points of this problem is the most common diabetes related eye diseases are diabetic retinopathy and the cataract. Diabetic retinopathy is the major cause of irreversible sight loss. That we have to keep in mind. It is a major cause of irreversible sight loss when it comes to a certain degree, but we can prevent it. Those diabetes have increased risk of other retinal vascular diseases. Good diabetic control is the best treatment. Right? Control of the respectors play a major role. Attendance, this is the major thing. The attendance for diabetic screening is important, and patients should be supported to keep their appointments. This can be done by you all. And practice should try and maintain up-to-date diabetic register. Sometimes the patient comes, you have to keep it in mind in your book that patient is seen by ophthalmologist, or otherwise we have to refer them to do that. Thank you very much.
Thank you, Kapila, for that very informative speech. Now I would like to invite Dr. Mrs. Mangala Gamuge, Consultant Eye Surgeon of Namalok Hospital, Colombo. She is the current National Coordinator for the Vision 2020 program to deliver her lecture on ocular trauma and emergencies at primary eye care level.
මේකෙන් යන්න පුළුවන් මේක මෙහා පැත්තෙන් තියෙනවා. Good evening to everybody. I thank College of Ophthalmologists for inviting me for the lecture. I'm supposed to do a lecture on ocular emergencies and trauma. I will try to make it simple as much as possible. So I'm going to talk about physical injuries and chemical injuries under trauma, and infections, painless loss of vision, and others like acute glaucoma, painful third nerve, uveitis, and giant cell arteritis as ocular emergencies. So we'll start with orbital infections. This is one of the most difficult subjects. So there are different types of orbital cellulitis, different grades actually. So one is, sorry, I have not put a picture to show you the globe, orbit. So orbital cellulitis, there is the socket and there is an eyeball and surrounding structures. So the orbital cellulitis means that is infection and inflammation involved in the orbital tissues outside the globe. There's a thing called preseptal cellulitis where there is an eyelid and there is a thing called orbital septum where it make this division, anterior to the septum and the posterior to the septum. So when there's inflammation anterior to the septum, it's called preseptal cellulitis. In addition, there can be a collection of pus in the orbit forming abscess, and there can be abscess forming under the periosteum. And one of the most the severe form is the cavernous sinus thrombosis. That's what I have noticed here. So usually the clinical features are, they usually have eye pain and redness, lid swelling, there are some mistakes. The chemosis, that is swelling of the conjunctiva, and proptosis, and limitation of eye movements, and globe displacement. I'll show you with the pictures. This one is a preseptal cellulitis. There is a lid swelling, because sometimes the distinction may be difficult. So this is a lid swelling, there is periorbital swelling. Periorbital swelling, there is redness, there may be eye discharge and tearing. patient is not that ill. This is the inflammation in front of the orbital septum. But this is severe orbital cellulitis with orbital abscess. So there is proptosis, there is periorbital swelling, there is chemosis, and there is limitation of eye movements and dilated pupils. The bottom one is the patient is having both preceptor cellulitis as well as the orbit. Because when we get a case like this, one of the most important thing is, and this is just to show what is periorbital subperiosteal abscess, where there is a collection of fluid under the periosteum. So clinically, it's very difficult to see whether it is a subperiosteal abscess or whether it is orbital abscess, but that is actually confirmed by the imaging. This is a CT scan. So final one, the most severe form and the dangerous one is the bilateral. This is a cavernous sinus thrombosis where the patient is having orbital cellulitis, severe orbital cellulitis on this side, and has got cavernous sinus thrombosis. The patient is having bilateral proptosis, mostly on the affected side, chemosis, limitation of movements. So when you get a patient like this, in examination, there are few things we have to check. One thing is the visual acuity is one of the most important thing. We have to check for the pupillary reflex because that indicates, and when there is an orbital abscess or something occupying the orbit, if it is compressed in the optic nerve, so the patient will have poor vision and there will be abnormalities in the pupillary reflex. That is what is called apparent pupillary defect. So with that, when there's exposure, when there's proptosis of the eyeball, protrusion of the globe, the patient may not be able to close the eyelids properly. The patient will have corneal exposure and there will be limitation of movement. So the eyesight is threatened because of the two things. One is the corneal exposure, other one is optic nerve compression. So, because we have not done everything, we have to actually do the hematological investigations and the imaging. It may be either CT scan or MRI scan, and to decide the location of the lesion, if there's abscess, where it is located, and amount of optic nerve compression. So with that, of course, they have to be treated with systemic antibiotics. And if there's an abscess, we have to drain it. If it is causing optic nerve compression, we have to go for surgery. So in your point of view, if you see a case like this, if the patient is close by, of course, the best thing would be to send the patient as early as possible for us to see, because we have to start systemic antibiotics as early as possible. So in case there is some delay in sending, if there is a delay, of course, this is all right starting broad spectrum antibiotics, IV antibiotics. IV usually starting something like Silacef and Flagyl. Those are the common things we use at the beginning. So because those are sight-threatening conditions. Other one is, we'll go to the external eye, is a corneal ulcer, which is a common one. You have seen few pictures. When there is any corneal problem, usually they come with pain, redness, discharge, tearing, and photophobia. Those are few cases where this is when there is a corneal ulcer, you see a red eye and a corneal opacity. So if it is little more, so we'll see something like this. There's a fluid collection in the anterior chamber. It's called hypobion. Now there is furthermore, there's total corneal necrosis. It's a very severe form. Now, this corneal ulcers, it can be due to either bacteria or virus or fungus. Now, I think this Dr. Kapil showed us one slide because this is patient come with pain, tearing, redness, and you don't see much. So this is a viral ulcer. This is what's called dendritic ulcer due to herpes simplex. So if you put some fluorescein dye, it will show as a branching pattern. That is why we call it dendritic ulcer. But this type of case, if it is not responding and causing the bottom one, then this type of corneal, the possibility of fungal is there. So we have to quickly act on that and start vigorous treatment. Ideally, we have to look for, before starting treatment, we have to look for fungal scraping and look for fungus. But in your point of view, the patient coming with this and the patient cannot go to the eye surgeon immediately, or whether they are going to be delayed, it is all right starting antibiotic. If you send it without doing anything, that is, we can do the corneal fungal scraping, and some people do culture also. But otherwise, if there's a delay, of course, you can start on antibiotic, only antibiotic. The important thing is do not start on any topical steroids. So because this is, when it heals, anyway, there are going to be a corneal opacity. So patient is left with some amount of visual impairment. So if you see when you see a patient, this is just to say, when you see a patient like this, and there is ulcer, and if you see there are few tiny lesions around that, those are called satellite lesions. That is more in favor of fungal etiology. And if you generally you examine the torch, and if there is, when you examine the torch, if you can possible, try and see whether the anterior chamber depth is normal. If it is the cornea is there, and if the iris is touching the cornea, that means anterior chamber is flat, that means cornea has perforated. So this is usually these causes are the trauma, especially in fungal ulcers, and tear deficiencies or ocular surface disorders. Any ocular surface disorders where there is a tear deficiency and where the topical immunological response is poor, they are more prone to get corneal ulcers. Other one is like seventh nerve palsy, then there's a corneal exposure, they are more prone to get corneal ulcers. So treatment-wise, we give topical antibiotics, and some people get subconjunctival antibiotics, and we generally don't give systemic antibiotics for corneal ulcers. So commonly used antibiotics I have mentioned. So this safely you can use, but if you want to start on some corneal antibiotics, use commonly used antibiotics, and then go for the other rest. But best thing would be to send them as early as possible. So because as I said, one is a corneal scarring, other one is a perforation. The ulcer can progress and the ulcer can perforate. So there can be prolapse of all the eye contents. And at the same time, the infection can spread to the inside the eye, that is called endophthalmitis, or it can spread to the whole orbit as well, that is called panophthalmitis. Those are the complications of a corneal ulcer. So we'll go, there's a thing called endophthalmitis, that is infection involved in the intraocular tissue. This is one of the severe form. And those can be, there are two reasons. One thing is exogenous and the other thing is endogenous. Exogenous, that is usually due to either trauma or after surgery, post-traumatic one. And that actually the endophthalmitis is a very devastating condition that can cause a loss of sight as well as the loss of eye. Sometimes we may have to remove the whole eye. So they say if you see a patient with this severe pain, I will go to those are the symptoms actually. Patient will have severe pain, redness, chemosis. They may or may not have lid swelling, and they are extremely sensitive to bright light, and there is visual impairment. So with that, the patient come into you, and if you see a case like this, the cornea is okay. Sometimes there can be a collection of pus in the anterior chamber, but when you see, you look a whitish type of reflex inside. That means the vitreous is cloudy. If you dilate and have a look, you will not see the fundus clearly. You will have a very hazy view, and you will see some white opacities. So this is the clinical picture to judge that it is an intraocular infection. So when you see a case like this, of course, this has to be sent as early as possible because the management is quite different. We have to give intravitreal antibiotics, do the vitreous cultures and things, because if we don't act quickly, the patient can lose the eye. Usually this endogenous, so if you know, the endogenous endophthalmitis is can be, I said, traumatic, or it can be a hematological spread of the organisms from a distance or something like and the patient is having endocarditis, patient can go into endophthalmitis. Or fungal endophthalmitis can be seen in cases like patient is having a malignancy where the body immunological response is very poor. or intravenous drug users. The patient who has had long-term systemic antibiotics, the immunity is poor, so they are more prone to get fungal infections. So alcoholics and the diabetes mellitus, their immunity is very poor. They are the people who are more prone to get endogenous type of endophthalmitis. So we will go for the painless loss of vision. This is one of the emergencies. I have listed few common things. One thing is a retinal detachment, central retinal artery occlusion or branch retinal artery occlusion, central retinal vein occlusion, branch retinal vein occlusion, vitreous hemorrhage, wet macular degeneration, and giant cell artery I have mentioned with reason. So when you see a case like this who is coming with a sudden loss of vision, painless loss of vision, in the history there are few things you have to ask. Whether it is intermittent or whether it is constant, that is important. And whether it is stable or whether it is getting worse. And on examination, we have to have visual acuity, color vision, pupillary reflex. You have to feel for carotids and see whether they are all right, whether you see a bruit, and check for superficial temporal artery pulsation. So then we'll take the retinal detachment. This is a separation of retina from its normal position. It pulls away from the normal position. So the causes are the retinal tear or a traction on the retina. Dr. Kapila explained about the diabetic traction detachment. Or can be the collection of fluid under the retina. That is called exudative type of retinal detachment. So a patient who is coming with a history of floaters and flashes, those are the very important premonitored symptoms. Because if you can get a patient like this and say, I have flashes and floaters of vision, please send them for eye examination, because those are the initial stages where there's a retinal tear. Those cases is very easy to treat. When they get a detachment, what they say is, I have got something like a curtain in front of me. So I have two pictures because this has to be a dilated fundoscope. You have to dilate fully. Of course, these days, of course, difficult to see because of this COVID problem, and you can get a photograph, but otherwise, in normal practice, you can dilate, have a look. The top one, actually, if you look at the end of ophthalmoscope, you will see this is the normal retina. This is a little color change, something like a grayish retina, little bit elevated. There is a suggestion of, you can have suspicion. Of course, we have various type of lenses to examine. You can see there's a retinal detachment. When the retina is elevated, it gives a little whitish appearance, and there is a tear. So this is how it is seen in fundoscopic examination. And then the other one is when the whole retina is involved, the vision is very poor. But when there is a retinal detachment, without involving the macula, vision is good. So those are the urgent cases where we had to take them for surgery, and the visual recovery is very good. So the risk factors for retinal detachments are this aging, the family history. If the patient is high myopic and refractive error, they are more prone to get retinal degenerative changes causing retinal tears and detachment. Previous eye surgeries like cataract surgery, previous eye injuries, and so there are some people who have peripheral retinal degeneration. They are on their own, they get peripheral retinal degeneration, they get retinal tears, get retinal detachment. See, all of these cases, if there is any suspicion of a retinal detachment, so we have to dilate and have a look with the full dilatation of pupil. And the retinal detachment, of course, treatment is surgery. Early treatment, the results are successful, very good. So we'll go for the central retinal artery occlusion and the branch retinal artery occlusion. This is obstruction of you have seen some fundus pictures, obstruction of a central retinal artery or a branch. Little bit more, usually the males are common in little males. The 1 to 2% can be bilateral, but in general they are unilateral. In central retinal artery occlusion, the visual loss can be irreversible. So, because that is why it is important. Now, this is, if you look at if you look at fundus with a patient with central retinal artery occlusion, this is how it is seen. The eye is a center. When you see, you can see a red spot that is called cherry red spot. And the surrounding retina is edematous and white and pale. So when the retina is edematous only, you see the macula at the center. This is what is called cherry red spot. It's not it's very easy to see. You can dilate and have a look with the ophthalmoscope. Now this is the branch arterial occlusion where there is a small branch is occluded where you see the ischemic pale retina as a white area. If it is involved in the macular area, the patient will have good vision, poor vision. Otherwise, the patient will have only a shadow involved in the only the part. So they will have either the shadow in front of the eye, and if it is a branch arterial occlusion, they will have a field defect. They have light sensitivity, loss of light sensitivity, and loss of contrast sensitivity. And there's a thing called amaurosis fugax, that is intermittent transient blurring of vision. So if the patient comes and say, I have transient loss of vision, it recovers quickly. That is a very important sign because you have to have a patient has to be assessed. Carotids, cardiac, systemic hematological investigations has to be assessed because they can go into something like arterial occlusion or vein occlusion. And all these cases, both these are vascular occlusions. I have explained all these things. This is obstruction can be from a emboli. The emboli is usually from a distant place, so it can be carotids, it can be aortic arch, it can be ophthalmic artery or proximal central retinal artery. So we have to look for the etiology, why the patient has got this arterial occlusion, because the patient can get the same problem in the other eye. So systemic associations are hypertension, carotid atherosclerosis, left ventricular hypertrophy, IV drug users, the lipid emboli, diabetes, and some cases like post-surgical, especially the cases like orbital surgery. So the treatment there has been, it's a little bit thing, when are we going to treat? Is it recoverable? Now there is a little time limit. Those people say it is after 7 years, if you treat, these results are very good. Now you can try up to 24 hours. So the important thing is you have to get the intraocular pressure down. So you put the patient flat and do the massaging and give an IV mannitol to get the pressure down. And at the same time, there are some drugs you can use, oral Diamox. Diamox orally, we have IV Diamox also. And there are some other things advised are hyperbaric oxygen is 95% oxygen and 5% carbon dioxide. So this can be tried up to 24 hours. After that, of course, starting treatment of that is not going to be of use because there irreversible damage has occurred. So we have done the retinal vein of artery occlusion. We go for the retinal vein occlusion. It can be central retinal vein or the branch vein occlusion, because they are usually come with visual loss in central retinal arterial occlusion and the visual field defect like in branch retinal vein occlusion. So this is, I think you have seen already, Dr. Kapil has shown. This is a picture of central retinal vein occlusion. Optic disc is, you can see, but disc margins are blurred and there are diffuse hemorrhages, and these white things are cotton wool spots. And this is the branch vein occlusion. I mean, if it is a very commonly it is upper temporal you get, and you get involved the macula also and you get macular edema, and that is why the vision is poor even in branch vein occlusion, and you see these white things are cotton wool spots. So this again the risk factors: hypertension, atherosclerosis, smoking, glaucoma, antiphospholipid syndromes. And in young people, actually it's little different, and most of the people in drug abuse, infections like HIV, limb disease, syphilis, those are more common in young people to give rise to vein occlusion. So I had a rush because I had to do the trauma also. And the other one is a vitreous hemorrhage. You have seen some vitreous hemorrhage from Dr. Kapila showed in diabetic. This is actually the bleeding into the vitreous. It can come up from the normal blood vessels, that is following trauma, or there's a thing called posterior vitreous detachment. The vitreous gets separated from various places from the retina, and you tear the normal vessels and then bleed. Or the retinal tear can bleed, and there's a thing called tersons, as you must have heard it. And at the same time, the patient can bleed from the abnormal vessels, something like diabetic retinopathy. They get abnormal fine vessels where they bleed. Diabetic retinopathy, sickle cell retinopathy, those are the common ones. And there's a thing called retinal macroaneurysms, Coats disease, there are vascular malformation. They also can give rise to vitreous hemorrhage. That is how the picture looks like. So you have seen pictures. Now this is in the vitreous. There are two places. Now the vitreous is there and retina is there. There's a small space between the vitreous and the retina, that is called subhyaloid space. When the blood is collected in that space and you see a fluid level like thing, and that is called subhyaloid hemorrhage. So if you see a case like this, if you can say that as early as possible, this can be treated with laser treatment, that blood can be drained. But this one, next one is of course, now when you look at the fundus, you will see all very hazy and you get a reddish appearance. So it's a severe hemorrhage. So examinations, of course, you have to do the dilated funduscopy and you will not get clear vision. But if there are some few blood particles in the vitreous, you can see them as dark aggregates. So other one is acute glaucoma. I think this you heard about Dr. Pradeepa and Mudita about glaucoma. The acute glaucoma is again a very emergency. This occurs when there is a sudden rise of intraocular pressure inside the eye. They will have severe pain, red eye, reduced vision, and headache. Actually, most of the patients are admitted to a medical ward thinking that it is something intracranial. And when you examine the patient will have cornea is hazy. I will show you the picture. It's easy to understand. The cornea is hazy, pupil is dilated, not reacting. Sometimes the pupil is oval, dilated and oval, and non-reacting. The redness is mainly around the cornea, that is circumcorneal injection. And if you, because you will not examine in the slit lamp, but you can digitally check. If you keep both fingers like this and digitally, it will be very hard. So this is again a real emergency. Only thing is, if there is there are going to be any delay in sending the patient, because when the intraocular pressure is very high, what will happen is it compresses the optic nerve. So it causes optic nerve damage. So and that can cause actually irreversible sight loss. So we have to treat them, take them for treatment as early as possible, and they have to be referred early. Again, in case there is any delay, it's okay giving oral Diamox and IV mannitol. They are treated with laser treatment. Some people get laser treatment only, some people get surgery, depending on the severity. So there are some cases where people come with acute glaucomas other than the primary angle glaucoma. One thing is subluxated lens. Sometimes people with trauma or some medical diseases, patient gets the lens is subluxated. That can cause a secondary type of angle glaucoma. Or cases like uveitis, especially iritis, again inflammatory process that blocks the angle. The patient can have acute glaucoma. So other one is a painful third nerve I have mentioned. That is actually if you get a patient with a third nerve palsy, of course we have seen third nerve palsy, complete ptosis, ophthalmolgia, the exotropic eye. And you have to look at I think even medical student practice, you have to look at the pupil. If the pupil is normal, we say medical third nerve. If the pupil is dilated, we say surgical third nerve. At initial stages, even in aneurysm, it can be little misleading. Of course, if it is dilated, there's no doubt it is the surgical third nerve. So it can be commonly due to a posterior communicating artery aneurysm which is leaking, or in a head injury like extradural, subdural. Those are real emergencies. You have to refer them as early as possible. And other one is, so we'll go for the trauma. Trauma, this I said, it can be chemical injury or it can be physical injury. So chemical injury is one of the two emergencies. It can be due to acid or it can be due to alkali. Acids are something like sulfuric, nitric, chromic. Alkalis, common examples are fertilizers, drain cleaners, cosmetics. So actually the damage, depending on the type of chemical, the volume of chemical, and the concentration of the solution, the duration of exposure, and degree of penetration. So acids, what will happen is it dissociates into hydrogen ions and anions. So anions coating protein denature and precipitate collagen, and the hydrogen damages ocular surface. At the same time, alkali dissociate into hydrogen and cations and causes deep penetration, and the damage is more actually with alkali. So the clinical features can vary depending on the severity. It can be just mild corneal involvement and conjunctival inflammation. So patient will come with tearing, pain, chemosis, photophobia, and visual impairment, again depending on the degree. So it can be just a hazy cornea, and usually when you get the chemicals into the eye, the pupils, we keep the pupil dilated. That is why the people are dilated. Or it can be severe conjunctival ischemia. So it may be only small corneal erosions or hazy cornea with little more damage. If there is conjunctival ischemia or severe limbal ischemia like this, it can be this one. The white part is severe limbal ischemia where the prognosis is going to be very poor and they have to be attended very early. So in your point of view, this is immediate treatment is the irrigation. So you have to continue irrigation between half an hour to 1 hour. So what you can do is get a saline, connect it to the butterfly, cut the needle and put it onto the eyelid, and then continuous irrigation is the most important. You can use high isotonic saline, and ideal thing is to put a litmus and continue it until the pH is 1.5. So remaining, if it is especially in alkali burns, if there are remaining particles, you have to remove the particles. Otherwise, it keeps on continuously damaging the structures. Other than that, we have to give topical antibiotics. We have to give topical citrates, which is not available at the moment. Topical ascorbate, cycloplegics that to keep the eye dilated, that will cause less pain. Tear supplements, oral doxycycline, and steroids. But you can do irrigation when you get a patient like this. Copious irrigation is needed, and put some antibiotics and send the patient as early as possible. But of course, the patient has got severe burns involved in the face, chest, and other parts of the body. Please attend to the general condition of the patient and then send the patient. So we'll go for the trauma, physical injury. So this actually, ocular trauma is the cause of blindness in more than 500,000 people worldwide, and partial loss of eyesight in many more. And it is often the leading cause of unilateral loss of vision, particularly in developing countries. So we really have to take a little bit of attention on that. If you get an etiological classification, it may be accidental, or it may be self-inflicted, or it may be occupational. So the physical trauma, and we have to classify further, it may be penetrating wound, or it may be a non-penetrating wound, or it can be blunt trauma. And it also can be due to thermal trauma like heat and cold, and radiation trauma like ionizing radiation, ultraviolet light, and laser burn. So in primary evaluation, we have to see whether it is an open globe injury where the full thickness defect in the eye cords, and closed globe injuries without full thickness cause injury. So when you examine and evaluate a patient with a trauma, so I will, to make it easier, I will start with the periocular hematoma. This is a periocular hematoma where you will see the swelling with some cloth. And this moment, it may be difficult for you to assess whether there is a globe rupture, whether there is a fracture of the orbital bone. We may have to actually wait until the edema settles. So it may be a globe injury, it may be roof orbital wall fractures, or maybe a basal structure fracture. Thus we have to be monitored very, very closely. So, and if you go into a little more lacerations, it may be superficial skin laceration where you can clean and put a steri tape and you can clean. If there's something which has to be sutured, especially the eyelid, where there's a laceration involved in the lid margin or the tear duct. So there are those cases actually after we had to do and repair early before it gets infected. So in those cases, of course, systemic antibiotics is all right. We start systemic antibiotics to avoid it getting infected. And in blunt trauma, cases like corneal abrasions, stromal edema, tears in decimal membrane, those actually they gradually will heal. But there are cases like traumatic hyphema, of course, will have to be attended to. And there are complications in lens, cataract, subluxation, and dislocation. So I have shown a few pictures to be easier. Now this is a traumatic hyphema. So when there is if we get a case like this, these people actually, they have to have adequate rest, but that is one thing important. Other one is, okay, we will have to check the intraocular pressure. So there is a chance that the intraocular pressure goes up. So this is this is what is called, as you can see, a hole in the iris. This is called iridodialysis. So those are they don't have to, they can send them, not immediately, don't have to refer them immediately, but send them for further assessment because they are the intraocular pressure. Sometimes the intraocular pressure can go up. Sometimes if it is associated with the ciliary body detachment, pressure can be very low. So they have to be managed accordingly. Now this is, next one is a subluxated lens. Sometimes what happens is the lens can get dislocated into the anterior chamber. The intraocular pressure can go up to very high levels. So those are, of course, emergencies. They have to be treated as early as possible. So then we go into the penetrating trauma. That was a little bit important because they can be, the lacerations can be various at level, or we see easy for me to explain with pictures. So it can be a corneal laceration where this is a iris prolapse as well as the vitreous prolapse. This is a cut cornea with corneal laceration, full thickness corneal laceration with traumatic cataract. So this is the patient where there is a scleral laceration with prolapse of uveal tissue. Other one is a ruptured globes. These cases, of course, they had to be transferred or send them as early as possible. And I had to be covered with a sterile iPad. And if it is available, preservative-free eye drops can be used. Put some preservative-free eye drops and put an iPad and send the patient as early as possible. Only important thing is to detect. Sometimes these things like this scleral rupture, sometimes you might not miss unless you open the eyelids and have a look. There's a chance that it can be missed. So then we'll go into the orbital trauma. Now, if you see a case like this, there are all our patients. In a case like this, they will see that it is important, it is easy, so send the patient. Now, we have to assess them in a very systematic way. So it can be a very mild lid laceration, like this, lid laceration, not up to the severe injury. So when we assess periocular injury, we have to look at the eyelid, orbit. It can be facial injury, lacrimal injury, brain injury, and nasal sinuses. These are the cases more present most of the accident and emergency. So you have to be stabilized, and the initial triage is very important. So we have to assess the associated periocular injuries and review. So we have to look for whether the patient is having a very acute threatening condition, sight-threatening condition, and evaluate them systematically to manage. So we have to, and in our case, of course, we have to maximize our primary treatment and to minimize the need for secondary intervention, that the results are going to be very good in that case. So, and these people, when you examine, it has to be guided by the history. So we have to have a high index of suspicion, and examination has to be informed very delicately. And initially vision may be good, but that doesn't mean that there's no ocular injury. We have to continuously monitor the patient. So the things like periorbital ecchymosis, contusion, as I showed earlier, is important. Usually it is accompanied by pain. At the same time, you have to assess the position of the eyeball. One eye may be depressed, other eye may be proptose. So when it is depressed, that means in ophthalmos, that indicates that there is a ocular or orbital fracture. And look for orbital margin and see whether there is a defect that indicates that there is an orbital fracture. And the periorbital anesthesia, that means there is a fracture of the involved in the orbital floor where the inferior orbital margin is affected. So subcutaneous emphysema is important because there is an opening into the sinuses. Those are the very important physical signs we have to look for. So this case, this boy with a trauma, patient came like this. There is a left eye is depressed down because there is a hematoma superiorly. But this one vision is good because the hematoma is superior. There is no optic nerve compression. So he was managed conservatively. This lady, there was a retroorbital hemorrhage. There was mild proptosis, but there was no optic nerve compression managed conservatively. But this is the very dangerous one. This is a very tight eye. There is a severe orbital hemorrhage, tight eye. The orbital nerve is, optic nerve is compressed, and they had to be, in this kind of case has to be taken for surgery immediately if we have to recover the sight. And this boy, of course, this is when you look at a patient coming with history of trauma, and we see only a small ulcer-like thing here, and we are not worried, and the thing is that there is nothing urgent, but you have to get a very detailed history and the type of injury, and whether something has gone in, if it is an injury with a stick or something like, whether it was broken, this type of things has to be asked in the history, and we have to go for imaging because this one is having a orbital foreign body. So other one is the most dangerous one of the complications following trauma is a keratoconcavenous fistula. So it can be a minor one like the bottom one, very mild proptosis with the very limitation of ocular movements, but patient is not that sick. That is an indirect type of keratoconcavenous fistula, but this is a severe proptosis. Severe proptosis, chemosis, ophthalmoplegia. And there, if you look, there is a severely engorged episcleral vessels, and if you see imaging, there is a severely dilated superior ophthalmic veins. They are all in favor of keratoconcavenous fistula. They are, of course, they also have to be assessed, diagnosed early, and treat them. So I just showed, I want to show this, but this girl, of course, they came with proptosis, chemosis, limitation of eye movements. Patient looks very ill, sick. So you might think that this is a orbital cellulitis. But in children, if you see a case like this, there is a thing called rhabdomyosarcoma. This is, they always present like, very commonly they will present like orbital cellulitis. So this type of cases, of course, has to be transferred, sent early as early as possible for us to do the rest of the investigations. And with following orbital trauma, just talk few words about orbital fractures. So when there is a orbital trauma, it can cause bony damage or it can cause soft tissue damage. Soft tissue damage, it may be injury to the eyeball, injury to the optic nerve, muscles, connective tissues, or it can be vascular damage or lacrimal damage. So orbital fractures actually you see very commonly with the mid-facial trauma. So fracture may be limited only to the orbit or maybe combined with the surrounding bone with the zygoma, maxilla, ethmoid, etc. So again, the clinical examination is important. This man came with a history of trauma. So if you look very carefully, there at the right eye as if you have gone in. He has got ophthalmos. There is limitation of elevation with double vision. So in those cases, of course, we have to do the imaging. He has got an orbital fracture. Right eye orbital fracture is a herniation of orbital contents into the maxillary sinus. So other one is, this is very obvious, orbital flow fracture. Right eye ophthalmos, very marked ophthalmos. He has got orbital fracture with herniation. So those cases, even when we examine and diagnose orbital fracture, we don't do immediate surgery. We give them antibiotics, get the wait until the the edema settles, and then reassess. We generally go and inspect, observe them for 2 weeks, reassess and see whether they really need surgery. If they have diploma in primary position or they are severe ophthalmos, those are the usual indications for surgery. So actually, it's the initial assessment is the one that is important in this type of orbital trauma. So thank you very much.
Thank you, Madam Gamage. Some lectures were not being questioned. So if you have any question for any speaker, we can answer now. Right. I invite Dr. Ananda Pereira to give a certificate of appreciation to the speakers. Dr. Pradeepa Srivardhana.
Thank you.
Dr. Mudita Kolatunga. She went.
Dr. Occular.
Right. Thanks. Thank you. Dr. Mangala Kamagi. There won't be any questions, seems to be there will be any questions. So as we conclude the program today, on behalf of the College of Ophthalmologists of Sri Lanka, I wish to thank Dr. Ananda Pereira, the President of Independent Medical Practitioners Association, and Dr. Hasari, the immediate past President, for collaborating with us to organize today's event. I thank all the guest speakers for accepting our invitation to be here today to deliver these very informative lectures despite their busy work schedule. A word of appreciation is extended to Mr. Dirk Klassen, Senior Business Manager of Elegant Eye Care, and his team for undertaking to sponsor this event. We are grateful to Elegant Eye Care for the continued support rendered towards the academic program of the college. I would also like to thank the administrative staff of the IMPA, Mrs. Champa and Mrs. Saman Mali Vevelwell and Mr. Mahesh from our college office for the support given to organize this clinical meeting today. We are also grateful to the OPA itself for providing the venue. Finally, I thank all the members of IMPA who are here today and all the others who have joined online to make this a very successful clinical meeting. Please enjoy the rest of the evening. Thank you.